deployment. One of the other doctors, Dr. Pravin George, who is a neurocritical care at Cleveland Clinic main campus, as well as Akron General, has also joined us on this phone call. So he will be contributing some information as well. So we went actually the week of April 17th to 24th, and this was well into the surge. And so we got to experience a lot of things that we never thought we would see in terms of a system that was overwhelmed by this COVID. The surge that we talked about that never manifested here, we actually saw it. Our typical day started 6 o'clock in Midtown Manhattan, and this is actually a weekday photo of Midtown Manhattan. You can see there's just not much traffic. And I would hazard a guess, maybe I heard 2 sirens the entire week I was there, and I didn't hear any yelling, no gunshots or anything. So most of the people were actually placed in Midtown Manhattan from the healthcare, as well as the National Guard, but I think it just made it a more centralized location for everything. So we would actually get picked up by our Lyft driver. And one of the interesting things about the Lyft drivers, they also evolved as the coronavirus struck the city. And every vehicle that we rode in actually had these plastic sheetings between the driver and the passenger compartment just to help minimize transmission. And it was sealed pretty tightly from the floor all the way to the ceiling. This is a picture of the LIE, or Long Island Expressway, which during rush hour is pretty dead. Apparently, it takes hour and 15 to hour and a half. I think Pravin, he grew up in Queens, so he could tell us a little bit more, but to get from Manhattan to the Queens Hospital took us 15, 20 minutes. So it was just amazing how silent the city was. So a little bit of what I'm going to talk about today is just some of the numbers. New York Presbyterian Queens Hospital was where we went to. Some of the challenges that the hospital system, which I think the whole city faced, and some of the approaches that they tried, some that worked, some that didn't work, as well as some effective strategies that was helpful, as well as some final takeaways. So this is a picture, stock photo I took out of Times Square. Just a regular night. For those of you who are aware of it, there's 330,000 visitors a day in Times Square, and this is Friday at 6 p.m. and there was absolutely no one. Pravin could actually tell us more about we did a run, which normally would take an hour. It took us about half an hour to go through various areas of the city.
Yeah, no, it's been it was a very, very ominous and surreal sight at the same time. It was very interesting to see how empty it was. Even Grand Central Station, right around 7 o'clock, which is normally rush hour on a Friday, I think we saw maybe 3 people there.
So Queens, by numbers, it's a population of 2.3 million, which is 27% of New York City. It is extremely diverse. There's also a lot of foreign-born, and many folks speak languages other than English. Pravin can actually tell us more about it, because he grew up there.
Sorry. Yeah. So I mean, Queens, by the numbers, as you can see there's a lot of Asians there. The Korean, Chinese, and Vietnamese population kind of really took over the past 10 to 20 years. Before that, there were a lot of Indians that actually were in that area. One of the biggest temples actually is in that area as well. But over the time, there was a lot of Chinese population that moved in, and when we were talking to some of the people there, they said that a lot of the immigrants actually from Wuhan were in that area as well.
So Friday afternoon on Broadway, once again, just barren. So Queens County was exceptionally hard hit by COVID-19. This was data from last week, and it showed that it was the top county in terms of confirmed cases in the United States. As you can see, most of these, other than Cook County and Chicago, are from the Bronx or from the New York City area. Not surprisingly, Queens also led in the number of deaths, with Detroit and Chicago breaking the list. So this was Grand Central Station on a normal day. And this is what we saw when we took our jog around the city at 6, 7 o'clock at night on a Friday afternoon or Friday evening. So Pravin, myself, and 2 other critical care doctors were assigned to New York Presbyterian Queens. For those of you who are not familiar, it's a fairly good sized hospital, 535 beds, level 1 trauma, has over 120,000 ER visits. To give you a little idea of what it compares to around here, it has 162,000 patient care days. Only Cleveland Clinic in the clinic system has more. Hillcrest, Fairview, and Akron General are good 2/3 or less than the patient care days that they have there. It's the accredited residency program in internal medicine, surgery, and emergency medicine, and has 5 medical subspecialty fellowships. So it has a decent size training program. This is a picture of Central Park. Once again, I ran through the whole loop of this on the Friday before I departed, and it drizzled lightly, but I think I saw maybe 7, 8 people in the 8-mile loop that I took. So one of the big issues that we all faced going into this and we were all afraid of was this whole surge idea. And these were, this was definitely a problem that New York City faced in itself. It had to do with bed capacity, equipment, personal protective equipment, and staffing. And we were lucky that we didn't really get to have to deal with these things in the Cleveland area, especially in the Cleveland Clinic system. Let's see, sorry. So I wanted to give a case of a patient that we saw on what they call the outreach service. It highlights a lot of the challenges that this hospital system faced and a lot of these hospital systems face. And my first 2 days there, I was on this outreach service, which was essentially a consult service on the floor. And this case is very similar to most everyone I saw those 2 days. During that 2 days, I probably saw about 20, 22 patients, as well as did some consults. And this is a 54-year-old Hispanic male, and there are a lot of Hispanics far out of proportion. I think we've been hearing about this throughout the country, far out of proportion to their demographic makeup. So anyways, he was diagnosed with COVID-19 7 days prior to admission, presented a progressive increase in oxygen requirements over the past 72 hours. And when we saw him, he was breathing pretty comfortably on a non-rebreather, and saturation was 84%. So the simple question is, what should the following should be done? Non-invasive positive pressure ventilation, intubation, transfer to ICU, placed on 15 liters per minute in addition to non-rebreather mask, or prone positioning with chest physiotherapy. So the answer seems pretty obvious, but this is sort of their battlefield mentality, is that in any other time in the world in a non-emergent situation, the first 3 answers are the most likely answers, with transfer to ICU being at least the bare minimum that one would do. In their case, if you were comfortable, you would not go to the ICU because they didn't have enough beds to go to the ICU. To give you an idea of the capacity issues that they had, New York Presbyterian, the Queens Hospital, had approximately 40 beds of ICU prior to coronavirus. They had a SICU, a CVICU for post-cabbages, CCU, and a MICU. And most of the MICU patients oftentimes were drug overdose, a lot of things you see in an inner city hospital. And so with the onset of the COVID, what happened was they far outstripped their capacity, and they ended up increasing from 40 beds to over 140 to 150 ventilators, such that they had patients on the medical floors with the ventilators. So what they did was they would actually put these patients on 15 liters per minute as long as they looked comfortable, which this gentleman did, and they would put them in a prone position, and the resident that I rounded with would actually do chest physiotherapy for 30, 40 seconds. And we had patients who would start out at 75%, and they would do this, and their saturations would increase. the prone position probably helped with some differential shunting. But even people that are already prone, somehow the chest physiotherapy, for whatever reason, seemed to alleviate their desaturations. Not much higher than 80-45%, however. Of the 20-some patients, I had maybe 1 or 2 that saturations with 90%. And it wasn't really till they got to about 81-82% and maybe look a little short of breath that we would actually consider bringing them to the ICU. Like I said, any other time, these patients would have gone to the ICU. And in the week or 2 after we left, these patients started getting mobilized into the ICU as space was cleared up. So this is a graph representative of a couple of things. It's a similar graph for them for their COVID admissions in a hospital, as well as their ICU admissions, as well as ventilators. They followed the exact same trend. And this is really looking at a 1-month flow sheet. And the big things they're looking at are from March 25th to April 13th to 14th. We showed up on the 17th, so by then the curve had flattened out. But to give you an idea, they had approximately 900 patients by March 25th with COVID, and that number almost tripled by April 13th. Ventilator and ICU, same thing. It started much lower, but it was about 3- to 4-fold increase in total ventilators and total ICU admissions in such a short period of time, such that we saw them adjust their units by creating units out of anything they could. Any place that they could put an ICU, they did. So Pravin and I were actually in the cath lab recovery, which was converted into ICU. And a cath lab recovery is a very tight space. It doesn't have much toiletry or faucets or anything, and we ended up making it work. It was pretty insane from that perspective. Pravin, do you have any thoughts about that?
Yeah, I mean, one of the things that they were talking about was they had a surge plan right in the beginning, and they had to scrap that plan almost immediately once they started realizing the kind of numbers that they were dealing with. They changed midway, and they basically said, you know, we need anywhere that has suction and oxygen. And they realized that their cath lab recovery unit was one of the areas that had probably one of the most area for that. So they literally moved all the beds out, and they just converted it into an ICU very quickly.
So this is just a quick picture of a snapshot of their ICU. And the greens are the open beds and reds are full. And they were packed. They were so packed that they had approximately 20 ventilators on the floor, on the medical floor, with nursing ratios of 1:10 to 1:14. By the time we got there, they were so excited because they finally were able to get all the all the intubated patients into the ICU. As you can imagine, having intubated patients who are paralyzed on multiple pressors on a medical floor being cared for by medical floor nursing is pretty much a recipe for disaster. And not surprisingly, there are a lot of patients that didn't do so well, such that a lot of the deaths did occur more on the floor than even in the ICU, just because they were just so overwhelmed. This next slide is actually of the LTV ventilators that you may have heard about from the national stockpile. This was a ventilator that they got shipped over to them. And I don't know how many, I think it seemed like they had more than half or 2/3 of their ventilators were these ones. These ventilators really do nothing. They blow some air into them, give the oxygen, that's about it. And when they first pulled these out of storage, they actually found that all the O-rings had to be replaced. They were all cracked. Not only that, for those of you who are aware of how ventilators work, there's, if you remember, there's something called PEEP, which is positive end expiratory pressure. In this disease, as we suspected it caused acute lung injury, traditional management of ARDS, or acute lung injury, is to have high levels of PEEP so people can oxygenate. With these machines, when you got above 15, which is in the moderate range for treatment of ARDS, the machines would pop off they would get disconnected because the tubing would be too much pressure for the tubing. So really made for a big challenge. Because this is a dot matrix screen, and they put it onto a chair next to the patient's beds, because it wasn't like the current ventilators, which are these big machines. You couldn't necessarily see if it was pressure alarming or any warnings, because you couldn't hear anything because of the large, loud HEPA filters that are ongoing and these things would just be blinking all the time. So you really had to pay a lot of attention to it. The machine on the right is a renal dialysis machine, and it's a lot of these folks develop acute kidney injury. They end up going to CRRT, and as a result, because there's too few of these machines, people would share 2 to 3 in a 24-hour period. And essentially, there'd be one machine between 2 patients in this tiny little cath lab recovery, which had maybe 2 feet between patients, had a dialysis machine between them, and then they essentially just clean it up and move it to the next patient. This is a picture of me and Pravin as we work together in the cath lab unit. This is the bunny suit, or the Tyvek suit that we would wear. Typically, these are meant for once a day. We use it for a whole week. A lot of this gear was also donated. As you can tell by my face covering, it's got Chinese writing on it, and Pravin's is more the American style version. He has a N95. I actually have a N95 underneath my surgical mask because we would wear that. They wanted us to try to wear the N95 for a whole week, but eventually they had enough, so we essentially just changed one out a day. But you'd wear a surgical mask and dispose of it as you went. We all know this wasn't what was discussed in terms of keeping everything sterile and clean, but this is the way they ended up having to deal with it. Pravin, any addition?
No, I mean, this was a great picture to kind of epitomize kind of what we were doing in there. But yeah, we actually, you can see we're actually wearing gloves under there just because we had to constantly change things, and we were worried about touching things with our hands in itself, and then we would alcohol and hand sanitize our gloves instead of everything else as well. But yeah, if there was an emergency in the unit, we didn't want to have to switch PPE or put it on right away or anything like that. We always were wearing it between patients so that we could respond quickly.
So this is a case, a pretty typical case that we saw, but in the ICU together. It's a 56-year-old Hispanic male, COVID-19, admitted to surgical ICU after having symptoms for about 5 days. During his hospitalization, he was intubated on day 4, paralyzed, prone ventilation, begun on CRRT, and was on 3 and at some point 4 vasopressors. His CRRT clotted and begun on heparin. And on day 6, he ended up having bilateral apical pneumothoraces, which required chest tube placement. Despite that, he had a pretty large air leak due to his bronchopulmonary fistula. And he kind of meandered along on a lot of pressors, intermittently paralyzed. He was once again prone for a long time, developed a lot of pressure sores on his face, and such to the point that Pravin lifted an IV tubing off his chest, and you could already see the beginnings of pressure sore forming just from the IV tubing. Day 14, he developed MDR Acinetobacter. One of the challenges with this case is it really represents the kind of the two-faced nature of ICU medicine, especially with COVID. So a lot of the things was related to COVID with his multiple organ system failure, dialysis line clotting and all that. But what happened is, because this was done early on in our understanding of the H and L phenotypes, he was ventilated on high pressures. He had a PEEP of 20 and he was on pressure control, and they put him on an inspiratory pressure of about 25 above that. For those of you who aren't familiar with events, we try to keep total plateau pressure under 30 to prevent pneumothoraces, but this guy, I think it was in the 40s, so it was not surprising that he ended up having pneumothorax. So I actually generally caused some issues. Now, as to the Acinetobacter, this, by the end of our stay, we started noticing some MDR Acinetobacters, and it actually became a pretty big outbreak. And I think when we left, it went from 1 to 2 on Tuesday. By the time we left on Thursday, I think it was like 14 or 15 cases throughout the 5 or 6 ICUs on different floors. And what we think happened is that potentially the prone team, which came and would prone people twice a day, they may not have been, they definitely weren't changing out their Tyvek suits, And it's unclear whether they ever even wiping it down for whatever benefit that might even have. And so they were still dealing with that when we left. Pravin, do you have anything else to add on that one?
Yeah, no, I mean, you hit it right there. But I mean, yeah, we saw a lot of ICU issues as well as, the traditional ICU issues in addition to the COVID ICU issues. And I mean, some of the things that we also saw in there, just because of the lack of manpower, and I'm not sure if you're going to hit on this a little bit, but especially nursing staff and RT staff, we did when Kar-Ming would round on his patients, what I would do is I would actually go for each patient and look at their IV poles, and there were usually about 12 or bags that were already used up. They were just hanging there empty. So I was starting to empty off the poles just because there were a lot of things there. Yeah.
Yeah, so that's a good point I forgot to mention. The other issue I didn't touch on as much was the staff, and that was obviously why we were asked to come to volunteer. The pulmonary critical care department for Queens consisted of approximately 12 people, but only about 9 were active. The other ones were in administration, and early on, about a fourth of them got sick. And so that created a lot of manpower issues, especially as they're ramping up. So they end up just getting a lot more physicians from the surgical ICU to help out. Now, same thing happened to the RTs. I'm not sure about the nursing, but I suspect it's very similar. And that was before they figured out what a lot of these issues. So that just further exacerbated the system. This picture is actually of a billboard that we saw. And I don't know if you guys have checked YouTube, but you can. At 7 p.m., people would open their windows and start clapping and shouting. We were in the hospital at the time, so we actually didn't get to see it, but we saw some videos, which is pretty inspiring. So there's no limit to how much health you can provide people. And this is from an Israeli historian, but what we found out is that you have to be super duper creative to figure out how to provide all that health. And so the approach that the people at Queens did before we came is an approach that most of us were thinking about prior to, as we were working for the surge. The beginning is that when your first COVID patient shows up, we were putting them in negative pressure. Subsequently, when they ran out of negative pressure rooms, we put them in a private room, and eventually we cohorted them into areas of the hospital. New York Presbyterian, with its 535 beds, they actually flexed higher. They were entirely COVID, with the exception of maybe 50 patients. So not only were they COVID positive, in the ICU, all the single organ failure ones, so people on ventilators, they got shipped over to Cornell, and so only the sickest of the sick stayed at Queens Hospital. And then we haven't seen the data yet, but I suspect the mortality data is much higher at Queens than it was at Cornell. Their ICUs, as we mentioned before, they started in the CCU, MICU, SICU. They end up going to cath lab recovery and PACU, and ultimately to the regular nursing floor. They actually were very happy when we showed up to tell us that they finally converted the cafeteria back from a medical COVID unit into a regular cafeteria again, that they could distribute food. So that was another milestone in their approach, that they knew the end was coming close. As to staffing times, they had initially worked on the typical 6-1 or 5 days on, 2 days off. And early on, they knew they needed more manpower, so they went on 7 on, 7 off. But with the illnesses and the stress of taking care of all these patients who were incredibly sick, they ended up going on a 3 on, 3 off. That was also so that they could minimize infecting different teams, as that was a big concern. There's clearly pros and cons with it. The biggest con was just the disjointed care, especially as you're mixing medical ICU trained people versus surgical ICU trained knowledge. The other thing that they tried, which Cleveland Clinic has actually talked about as well, is going to a supervisory mode, where you would have a physician who would oversee 2 or 3 residents, senior residents or fellows, or even non-medical attendings, and just help them with management. What they found out was these patients were so sick that they ended up going to direct management because they needed to take care of these patients more directly. And as a result, they went from 3 or 4 units to, at the peak, they had 9 units with approximately 10 critical care attendings manning it in any given day. And they really went to all hands on deck modality where the surgeons came and helped. The vascular surgeons would be part of a line team. I had a hand surgeon who would draw blood on rounds for me. And so it was really just to get through to the next day. Pravin, any thoughts?
Yeah, I mean, on top of that, I mean, we had floor nurses sometimes rotating down to the ICU, just trying to help out with anything that they could. Also on the side, we had a couple of CRNAs and NPs that also converted back to bedside. The only interesting thing about it was that some of them had not been at the bedside very long, or it's been a long time since they were at a critical care bedside. So there was a sharp learning curve because they were taking care of these patients all of a sudden in a COVID unit from where they were in a anesthesia area or some kind of other setting. So that was kind of an interesting transition for them as well.
Yeah, that's a great point. One of the challenges that you get when you get people who don't do ICU full time, is from a nursing perspective, is with these IV pumps running leave-it-fed paralytics. It'll tell you when these drips run out, and so you have an idea. Any up-to-date practicing ICU nurse will know to anticipate that the drip's going to run out in 20 minutes and get it ready. There was actually several cases where they weren't quite on the ball and the drips would run out, and the patients would either self-extubate or their pressures would drop until someone figured it out. Pravin did a great job cleaning out various drips, and we would see medications that we didn't even know the patients were on. I think they'd actually been offered for a few days. And the other funny thing is you can tell the difference between an ICU nurse and the floor nurse, because these IV poles would look like Christmas trees that were just in disarray with all these pumps here. And when an ICU nurse got through with it, they were lined up perfectly. You could read all the labels. You knew exactly what was going on. So it was a definite change midweek is when we noticed that. This is just a slide we saw walking in. They had a lot of these things to help motivate people. Some effective strategies. Pravin, you want to talk about these ones?
Yeah, I mean, they had, like you were saying earlier, the special teams that would come through. We had the proning team that would help out with things. They had the vascular access team, just an overall sense of a purpose for some of the people that weren't able to necessarily man things in the ICU. They were able to kind of do that. We had recharge areas throughout the hospital where they would have snacks, different things, because you're constantly on the go there. And these were kind of safe areas, COVID safe type of areas that would have not as many people in there, but I mean, it gave you a chance to settle out of the unit for a minute or two before you got back in. There was a twice-a-day briefing, both in the morning and in the evening, and we basically went over all of the numbers, whether they were admissions or just ICU beds, how many were closing, how many were opening, all of those type of things were there. And then the volunteer integration was really nice. I mean, this was a lot of people from a lot of different centers. I mean, I think when we were there as the Cleveland Clinic cohort, we had some from UCSF, from Intermountain, and then we had a whole bunch of traveling people that came in to integrate in, and it was effective in the way that we were able to at least get the unit pretty well.
So some things to improve on, Pravin touched on a little bit. They would have, they tried having an ICU nurse who would have 4 patients, which is obviously higher than their normal, oversee 2 floor nurses who would also have 4 patients each. So subsequently the ICU nurse would have essentially 12 patients under her service. And one of the good things that may have been helpful is if they would have had an ICU nurse overseeing 3 or 4 floor nurses, so she or he could have just moved around and offered suggestions. One of the other big things was communication with special teams would have been a helpful thing. These teams did a great job the challenge was that they were just kind of muscle, and so they didn't do as much critical thinking, which I know is the primary services job. However, there's so much going on, such that these things would, and with the team switching every 3 days, that things would get passed by. For example, people would be proning for days beyond what they should have been. And central lines that are put emergent in the groin would have been in there for a week and a half as these people were prone. And perhaps a better communication where someone would follow along and say, this is day 10 of this femoral line, and changing it to a PICC line would have been helpful. What Pravin touched on, I think, is probably one of the biggest things that probably would have made the biggest difference. It's really this attack leveling and blocking of ICU, which is due to best practices, oral care, wound care, lines, all those things. And I think with this disease, we all got freaked out by the fact that it was COVID. And it is a scary disease, but it's really just the initiating factor, and everything else becomes ICU medicine. And so right. I think in that panic, people turned away from that and was blaming everything on COVID. If you took care of those ICU issues, then you would go a long way to getting them better. I mean, we know as of now, there's not a whole lot of treatment for it. So that's been pretty good. Pravin, any thoughts?
Yeah, no, I completely echo that. I mean, I think one of the first things that we had to get over right as we got there was the fear of COVID itself. I mean, we obviously are in a much safer area here in Ohio, but you get into a hospital that's considered a COVID hospital, and you walk into that unit. I mean, there's just this fear around you that you're going to get it, or if a ventilator pops off or something like that. It took us a good maybe a good day, maybe two, to really kind of fill in and feel that we were more comfortable. And then once that started happening around that midweek time is saying, we were able to really kind of clear off the lines, do all the things that actually practice ICU care and get the care that these guys needed.
So one other thing I wanted to touch on was besides Pravin's issue, which is it's a great point. Like, I thought I was gonna get COVID, and now I realize because the fact I didn't get it there, it's really hard to get it if you gown up properly. But I had our intern who, as we know, all these hospitals are closed to people. So she stood holding an iPad about 2 feet away from this patient who was clearly dying, just so the family could see him one last time. So it's sometimes people can't see their loved ones, but and dying is a solo process, but most of us are lucky enough that we get to die with family nearby. But this is not what was happening. It was very sad from that perspective. Couple of takeaways. I'm trying to run through the last few slides quickly. Disaster preparedness and readiness drills will be helpful, but you never know until it happens. And then I think sometimes we start focusing too much on keeping the caregiver safe, and you lose a little bit of the patient care aspect of it. So we need to focus both on these things. We need to take a 30,000-foot view so we can see things and not just get bogged down. And finally, New York City could be anywhere. I mean, if it happened in Cleveland, same thing would have happened. This is our team for those 3 days. Made our residents, fellows, and here's the 4 of us from Cleveland Clinic. This is just an uplifting slide of how many people they discharged, how many people they discharged for a whole day. Oops, sorry. And then here's a little video of the airline staff as they volunteered to fly us out. It was the best time ever. They cleared up their stores, gave us wine and beer and candy. And oops, let me see if I can play that. Let's see. There we go. So. So there was that. And then when we got there, this is actually a slide of the New York City people working there. So they're very appreciative that we were there. So that's it.
Yeah, thank you, Kar-Ming. Thanks a lot. Now I will shift gear. Again, we welcome Dr. Fowle. Dr. Fowle, thank you for joining us. We have already given Dr. Mukunda, our BOT chair, has given your introduction. Thank you for giving us your time at the Mother's Day event. And now I'd like to welcome Dr. Shanu Agarwal. Dr. Shanu Agarwal is our infectious disease specialist and she's actually a lead in the Summit County for infectious disease. And Dr. File is our chief of the infectious disease. He's the president of the American Society of Infectious Disease. And here I will shift the lecture to Dr. Shanu Agarwal, and I work with Dr. File and Dr. Shanu Agarwal very closely, and it has been a great implementation of the infection control that was implemented, and we have dealt with a lot of patients with COVID on ventilators, on ECMO, and to an extent now we are also working on the various kind of renal replacement therapy. With that, I welcome Dr. File and Dr. Shanu Agarwal.
Thank you. Like Rupesh said, I'm Shanu Agarwal. I've been with the Department of Infectious Disease at SUMA for close to 14 years, currently chair of infection control, and have been the chair of infection control for almost 13 years. But I think that I really had my title as infection control was really put to the test with this crisis. And I'd like to thank Dr. File for being online here today. Dr. File is not only our chair of infectious disease, he's the president of the Infectious Disease Society of America. He's not only a colleague, but he's been a mentor for me all these years. And especially with this, I can't thank him enough for all his guidance. So thank you, Tom, for being on.
My pleasure. Thank you.
So our whole experience at SUMA was very different from Dr. Lo. I mean, we basically, after hearing all of your experiences, ours seems like it was much more controlled, I think, because our numbers were much lower. Just to give a timeline of events, and this is primarily from SUMA, in the first week of March, basically, we were just getting prepared for what was to come. We had discussions of placement of where we would place our COVID rule out patients from the emergency room. We had an incident command that met every day at 11:30. We also had plans at that time, which was early, but we already had plans to do a surge plan, setting up a mobile hospital and tents. We, further discussed isolation procedures. And the big issue in the first week of March was really the masks issues. We had noticed as there was a lot of hype on social media and the news, we found out the masks were being basically hoarded on floors from various folks, from visitors, and even some of the healthcare workers. We were noticing mass amounts of masks that were gone within days. So at that point, we really had to concentrate on mask and PPE conservation. We did a lot of education for the nurses, for the physicians, and all the staff at SUMA via town hall meetings that actually were led primarily by Dr. File. And these, after probably 1 week, they had basically turned into a video sort of education because we could not have so many people in a room because of the social distancing. By the second week of March, we had found out that there were 3 cases of COVID identified in Ohio. At that point, we had limited our visitation, limited in-person meetings, so all our incident commands were then done through phone calls and teleconferences. And what we sort of struggled with compared to the other hospitals in our area was that we had limited testing capability. So we did not have the ability to do in-house testing. We were waiting for different platforms to be received at our institution in our lab, and then that required validation. So we were really working on the inability to test, but then the possibility of having patients come into our institution. By the third week of March, we had our first few COVID cases in our hospital. At that point, we were able to at least send our swabs to ODH and to the reference labs, but those turnaround times ended up being close to 7+ days. So we were treating these patients were in isolation for those full 7 days. We were treating them as COVID. Of those first couple cases, probably about 2 or 3 were positive. The rest were all negative. And because we had limited testing capability, we really had to prioritize who we were testing. So it was a lot of writing protocols in that third week of March. We really had to prioritize based on x-ray findings, presentation. If we didn't rule out another disease, if we were able to rule out another disease, then we would sort of stop there and not rule them out for COVID. So we were really struggling. And this was really sort of a difficult part and challenging because we had to, I felt that I had to keep explaining to a lot of the physicians, a lot of the nurses, why we weren't testing people and that why we had to be so strict with our testing criteria because we were so limited with what we could do with our the amount of tests we had. We then also at the same time came up with preliminary treatment guidelines, which included hydroxychloroquine, plus or minus azithromycin, which at the time, with all the social media and what we had heard on, you know, from different case reports and anecdotal studies, we thought that it was probably going to be the best thing for these patients, and we were limiting who could have it. We, at that point, if you remember, even pharmacies were not allowed to dispense it without a diagnosis of COVID or an alternate diagnosis that for which you would require hydroxychloroquine. So shortly, as you all know, we had heard about all the side effects and maybe that it wasn't as great as we thought. So at this point, we're not using it on anybody. But in the beginning, we were using it on quite a few patients. And then by the 4th week of March, we had better testing capabilities. We had about 280 kits that we were sent in and 2 different platforms that we could test patients on. At that point, we were testing more. There were some patients that were admitted and were not in any precautions. And later we found out they were starting to have some sort of hypoxia. We would test them and they were positive. So we were struggling between we were finding out that patients during their 2nd or 3rd day of hospital admission that they were now testing positive. So we had upset nurses, upset healthcare workers, and then we sort of moved to a universal mask policy where everyone was required to wear a mask and a face shield. During that 4th week then we started having employees that were going out sick. And at that point, we had to sort of come up with a decision as what do we do with testing with employees? Again, because we had limited testing, we were unless they had symptoms, we were not, and even now, unless they have symptoms, we're not testing them. The asymptomatic employees we're allowing to come back who were exposed. And as long as they're asymptomatic, we're allowing them to work. And during that 4th week, again, we came up with further protocols and treatment guidelines. At that point, we really had supportive care as one of our top treatment recommendations, followed by all the other investigational drugs. So these were sort of the struggles. We didn't really struggle with having a surge of patients as much as sort of putting all these policies in place. And as Dr. Lo said, we really struggled with, or I feel like there was a lot of education as far as we felt a lot of the specialties were afraid to go in the rooms because they were afraid that they were going to be exposed. But, you know, now we're sort of trying to tell everybody that you have universal masks. We have a universal mask policy. Everyone is protected. And as Dr. Lo said, I think that you're probably best protected in the hospital because you're wearing all this gear. And in my opinion, more likely you're probably to get it from being out in the community. So that kind of takes me, so now after the 4th week, now during April, we basically were treating COVID patients, and our role as infectious disease was really more to help the ICU team, help pulmonary, help the other specialists that were sort of pulled to help with taking care of these patients. And we really served as consultants where we were helping them monitor inflammatory markers. For the most part, we really encouraged supportive care, but there were some circumstances where we thought that some of the investigational drugs were probably something to consider and use. And just to go through some of those drugs. So chloroquine or hydroxychloroquine, these are taken from the NIH guidelines. And at this time, there's insufficient data to support the use of chloroquine or hydroxychloroquine. What we did notice was that there is actually more side effects, prolonged QTc intervals. And just to give you a little anecdotal report, one of my first patients I had as COVID in the 2nd or 3rd week of March, I did give him hydroxychloroquine. He did come out of the hospital doing fine, but he did go into 3rd-degree heart block and required a pacemaker before discharge. So, and then with some other patients that we had on hydroxychloroquine on day 2 or day 3, they did have significant QTc prolongation. So, you know, and if I had to go back retrospectively looking at patients I treated with hydroxychloroquine versus those that I did not, and who had same risk factors, very similar risk factors, similar parameters, similar inflammatory markers. I did not see a difference really with both patients ended up going out of the hospital. Actually, the one who was not treated with hydroxychloroquine was discharged sooner. His days to recovery were a lot sooner than the one that was treated with hydroxychloroquine. So at this point, we're not really using the drug as much. Dr. File, do you have anything to add with the hydroxychloroquine?
No, I think you said it very well. Just anecdotally, it's interesting. I mean, you're showing the NIH guideline here. If you might recall, about a week before the NIH posted their guideline, IDSA actually posted our own guideline, which basically said that there's no evidence for benefit of any of these, quote, unproven interventions. We actually got some initial flack from that because we're saying, well, gosh, you're just saying there's nothing that we can do for the patients. But really, when you look at our guideline, as opposed to NIH, our guideline was really, truly grade level evidence-based guideline. And it really sort of humbles you when you realize that all the evidence that was there, including those studies from France, which obviously, you know, were extremely limited, suggested that there's just no benefit with this. But it was really interesting because we also, that is IDSA, also sponsored the NIH guideline because we had representatives from IDSA on that guideline. There was actually 35 people on the NIH guideline. And we were asked, that is IDSA was asked to come out with our guidelines first because NIH was concerned because remember, NIH is part of the administration. And you recall that the administration was really promoting hydroxychloroquine. And they were afraid that, at least I shouldn't say afraid, they were concerned that coming out with the NIH, i.e. administrative type of guideline, that they would get pushback from the White House that they wouldn't want these types of recommendations because the White House was so much promoting hydroxychloroquine. But eventually, then that's why they were delayed because we were supposed to come out together. That's why they were delayed about a week. But fortunately, the White House did okay them to give this recommendation. It's just an anecdote, but I thought it was interesting.
Yeah, no, thank you for that. And then the other investigational drugs that I have used personally, tocilizumab, which is a IL-6 monoclonal antibody, and used primarily for rheumatologic disorders. And again, there's nothing to really show the efficacy of tocilizumab in patients with COVID-19. There are some anecdotal reports of improved oxygenation. I will say, again, with tocilizumab, between myself and my partners, I would say about 50% of the patients who received tocilizumab did well, 50% of them did not as far as mortality and how many days they were in the hospital. What I have noticed is that the patients that I give it to sooner than later, so the patients that are having worsening respiratory failure on the way to intubation and giving the tocilizumab at that point, I felt that there was definitely was a significant, the timing of the tocilizumab was important in how the end result was, if you to give it a name. But at this point, I can't, it's hard to say whether or not it helps. The problem with tocilizumab is that it can down the road be important for adverse effects for patients, as far as if they were to have latent TB or any other sort of infections such as chronic hepatitis or something, could those infections start to sort of show up later? So that's yet to be determined with these patients who've received tocilizumab. Anything, Dr. File, on tocilizumab?
No, that's fine.
Okay. And then convalescent plasma. And so convalescent plasma, basically the idea is to give patients plasma from those patients who have recovered from COVID-19 and give it to those who are currently infected with it and quite sick. And we are part of a trial through Mayo Clinic. And so we have given plasma to a few of our patients and have seen some improvement. And again, I think with the plasma, our turnaround time is about 7+ days. We are getting some of the blood in sooner now. So I think that we'll get a better idea of the effectiveness of the plasma. but some of the first couple patients who received it, it was after about 7 days from when we got the blood in the blood bank. So I can't really say if it really improved their overall outcome. And then lastly, I think there's the remdesivir, and I'll let Dr. File speak about remdesivir if he doesn't mind.
Oh, that's fine. I mean, you may be aware that NIH actually, I think it was April 30th or 29th, actually reported their preliminary results of the randomized clinical trial. There was about 100, or no, it was about 1,000 some patients in this trial. So it was relatively robust. It was coordinated out of University of Nebraska. Andre Khalil was the primary investigator. But at any rate, just the data which they mentioned in their preliminary report was that the primary outcome, which was days to resolution of illness, was significantly less in the patients who received remdesivir versus placebo. It was, I think, 11 versus 15 or something like that, but that was statistically significant. If you looked at mortality, it almost reached statistical significance. It was p-value of 0.059, and it was 8 days versus 11 days. They really don't mention the safety profile in their preliminary report. But as you know, then 2 days later on May 1, FDA issued a emergency use authorization, and then it was started to be distributed last week, and there was a lot of confusion who was getting it. It seemed like there was not a very good equitable way of distributing it. IDSA actually wrote a letter to the task force addressed to both Vice President Pence and Secretary Azar, requesting a more transparent, equitable manner of distribution. And then many of you may have seen that yesterday, HHS came out with a more transparent policy where they are going to be sending it to the quote hot zones, the locations where there is higher incidence. So it's going to New York, it's going to Boston, it's going to Detroit, it's going to other places where there are more cases. And there's specific criteria. If you look at the report by HHS, basically, at least initially, it's going to be patients almost that require ICU or almost requiring intubation or certainly have significant hypoxia. And so at least now, there's criteria. They're sending it to the places where they need it most. And they've only distributed about 10% so far. I mean, they say that every state will get some aliquot of it, and then it's going to be up to the Department of Health of each state, therefore, to distribute it to where they feel it's going to be appropriate. But, and Gilead is donating this. They have just over about 1 million doses, which if you take it for 10 days, it's going to be enough for about 100,000 patients. And then, of course, they're ramping up production of it so that I'm sure they'll have commercial availability of it within a couple of weeks. And I have no idea how that's going to work, but that's the status with remdesivir right now.
Right. So those are the couple of treatment options that we've sort of, looked at for these patients. And then in addition, we are also in talks with Dr. Reyna in regards to using Cytozorb for some of these patients in cytokine storm. Where we are with COVID in our hospital is now that we've gone into phase 1 is the surgical, what to do for pre-op testing. Again, we are still with limited testing, so we're trying to sort of prioritize which surgeries we would test for prior to their surgery. So we've worked with the surgeons in length of developing criteria. There's some institutions that are testing all of their L&D and OB patients. Again, we do have a tier system for prioritization for all of these patients. Endoscopies TEEs. We've gotten a lot of questions from the physicians that they want their patients tested, but really we're trying to follow some sort of prioritization when we're doing testing for as we sort of ramp up the surgeries and procedures within the hospital. So that's kind of where we are now. Any questions for Dr. File or myself, or I guess Dr. Lo as well?
Hello, Dr. File, Dr. Kumar.
My question is, if there is an inadvertent exposure during a emergent procedure, and then the patient comes back as a positive COVID 3 days later, what should the staff be quarantined?
Well, Shanu, you want to, I mean, you're
So,
handling most of those questions.
Yeah, so what we are doing in our institution is basically, so you're saying that there's an exposure, right, to the patient after the procedure? Yeah, so what we're doing is as long as the healthcare worker is asymptomatic, we're recommending active monitoring. So temperature twice a day, but then presenting to work. And in our hospital, everyone is wearing a mask and a face shield. So universal masking and a face shield. And so we're allowing those workers to come back as long as they're asymptomatic. If they have any symptoms, then we test them through employee health, and they have to stay home until the test is received.
Yeah, that's our thought. And that's why we instituted this policy of so-called universal precautions. I mean, for those of you who remember back in the early 80s, we did this for HIV. And the concept was to consider that potentially any of our patients could be potentially positive. And so we would, everybody would use a certain PPE that should limit the transmission to themselves. So if a patient after a procedure or even an urgent procedure came back positive, there really should be very limited transmission for that. And I might also point out that last Thursday, IDSA posted guidelines for testing, and they did indicate that if you knew that patients, or even healthcare providers in this case, had a specific exposure to a known positive patient, but was not wearing PPE, and they're asymptomatic, as Shanu said, we would not test them right away. I mean, we would sort of follow them symptomatically. But if you were going to test them, the guideline, at least from IDSA, suggested that it would be reasonable to test them if they still remained asymptomatic at between day 5 and day 7. The thought being that that would be the greatest likelihood of being able to capture a positive test based on the potential viral load. But generally, I think what we do is allow these healthcare providers to continue working as long as they're asymptomatic. But obviously, if they develop symptoms, they're not supposed to come to the hospital, and then we would test them.
So there is automatic quarantine.
We are not quarantined unless they're symptomatic.
Dr. Kumar, if I may ask a question. A physician who has been tested positive, and I think return to work policy, how long is the virus being shed? And the return to policies, I think, is 10 days and 3 days after distribution, right? But is the virus continue to be shed later? Should they be wearing more protective gear for that?
Yeah. Let me just say, I was on a call about a week ago with, because I'm on a weekly call with CDC. And I don't know if you remember, but just last week, they changed their recommendations for the duration of timing for healthcare workers to go back to work. And you could use what they called a symptom strategy, not a testing strategy. Because what they found was, if you look at it in the literature, you can see patients testing PCR positive for 40 to 50 days. But they also did studies, CDD did studies to show that in these patients, you could not find viable virus, not culturable virus after 10 days. So that's why they went to this policy of 10 days after exposure. And if you had resolved your illness and were afebrile for the last 3 days of those 10 days, you could go back to work without having doing a test.
Hi, Dr. Agarwal, this is Prakash. I had one question. I just saw one patient who was admitted like 5 days ago. Suddenly she got desaturated from 2 liter and required 6 liter and then has to put BiPAP. And her CT just shows, I think we did for rule out T, but to our surprise, we find like there's a big right upper lobe pneumonia. And in the middle and lower, right lower lobe, there was some interstitial and the ground glass. So as Dr. Mehta said, like we retrospectively put him on the COVID precaution with the COVID testing, and we'll wait. Now we are doing in-house testing in Worcester Hospital too. So we'll see. But do you see pattern of lower pneumonia in this COVID pneumonia? Or because we just read it's a ground glass opacity in peripheral and basal area.
Right. I think, so what we've learned is that you can see almost, I think all bets are off at this point. You can see ground glass. What we thought initially was the ground glass appearance. That is the typical appearance that you would see. And that's what I've noticed most in someone who actually, we found some people who incidentally, like from a nursing home, who had no symptoms, but they had a chest x-ray and then there was some ground glass, but they didn't have any symptoms. But what, you know, Dr. File and I have kind of in the last couple of weeks, we felt anyone who came in with a respiratory issue or any type of pneumonia, you know, could there be a co-infection or could it be presenting, you know, different than ground glass appearance? So for someone as this patient, I would definitely have tested this patient because worsening hypoxia. And the key that I have noticed with these patients is that there's unexplained hypoxia, even if they're a COPD or they're not following the normal course with steroids and whatnot, they're getting worse and worse and worse. And actually we had a patient who was on the floor for almost 3 days with a COPD diagnosis, and I was called in as a second opinion. And, you know, despite being on high dose steroids, the hypoxia was getting worse, and I tested her and she was positive for COVID. So that's really the symptom of the hypoxia I've noticed is really is the key thing, that unexplained.
Yeah, and she doesn't have any chronic lung disease, non-smoker, doesn't have any exposure. And she didn't come with the fever. She still doesn't have fever. No mild cough maybe, but not any significant cough. But yeah, severe hypoxia, and her CO2 went up to 97. And we put her, now it's coming down on BiPAP. After 2 hours, it was 85. So it's showing, BiPAP is showing its effect, but.
Yeah, and I would agree to keep her in isolation until you have the testing received. And just to caution, now what we're seeing is a lot of COVID in the congregate settings, so nursing home patients, group homes, multiple group homes, and then also some of the refugees, Nepali population, and then we're seeing a lot of COVID positive. At least every day we're getting about 3 or 4. They're not all getting admitted, but they, when I look at the results, every 24 hours, I look at all the results in the hospital, and a lot from these congregate groups of individuals.
So retrospectively, should we test for all those who work with her?
So who work with who? Sorry.
Patient. Who work with the patient, like the staff members.
Oh, no, only if they were symptomatic. As long as they're wearing PPE, I wouldn't, unless they're symptomatic for healthcare workers. But, you know, and we tested a nursing home in our area, 110 patients. We tested the whole nursing home, 58 were positive. And not all of them had symptoms, so.
Thank you, Shanu.
Thank you.
And now this, because of the time constraint, I just want to thank everybody, especially the people and the workforce that is working on the webinar. Today is such a nice closing of our webinar to have a real lifetime experience with the COVID-19, and it is a pleasure to have Dr. File I want to thank all the EPNO committee. I want to thank our BOT chair, Dr. Mukunda. He's the one who brought me to EPNO. His vision, his education and research, making EPNO to go with the epitome of their success. I also want to thank Dr. Dharmesh Mehta and our CME committee. And again, from all the Association of Indian Physicians of North Ohio, and from the executive committee, we want to thank Dr. File to join and give his expertise. It was a pleasure to have you. And thank you, Shanu. Thank you, Dr. Agarwal. Sorry, I call you Shanu, Dr. Agarwal, Dr. Lo, and also Dr. Praveen. Thank you. Thanks a lot. All of you have a very happy Mother's Day. Thank you for giving your precious time in such an auspicious day. Thank you.
Thank you. Thank you.
Thank you. Thank you, Dr. Rupesh. Thank you, Dr. Tom. Everyone, nice presentation.
Thank you very much.
Thank you.
Thank you.
Thank you very much.
Thank you.